بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله، وأتمنى أن تكونوا جميعا بخير وصحة وعافية. In our last lecture, we gave an idea about the great neglected tropical diseases, which are the parasitic diseases, and we said they are great because they can cause a lot of misery, and they can also cause many fatalities, besides lost working hours, besides medical care of the ill individuals. And comparatively, they received less attention by the scientific community and less by money donors, and maybe also by comparatively WHO. We said we can divide parasitic infections into two, or parasites of medical importance into two or three categories. The parasites could be divided into those with simple structures, that is what we call single-celled organisms, and these are the protozoa. And then we have the bigger ones known as multicellular parasites, and the third group is belonging to the medical, or belonging to arthropods of medical importance. We said we can divide or group the protozoa into four groups if we consider just their locomotory structures. So some of them, they move by cytoplasmic extensions known as pseudopodia, and these are the amoebas. They are also called as sarcodina or rhizopoda. The second group move by web-like structures, and these are the flagellates, and we said this is a group including many parasites. For example, parasite of the intestinal system and parasite of blood and tissues, and some parasite of the urogenital systems. And today we're going to have an example of this parasite of the urogenital system. We said the amoebas, the flagellates, and the ciliates, you find some individuals which are free living and others which are parasitic. But all members of the sporozoa which lack locomotor structures, they are parasites. The multicellular parasites are divided into roundworms known as nematodes. For example, is Ascaris, Trichuris, and pinworm, hookworms, etc. The other are known as the flatworms or platyhelminths, and they could be divided into the cystodes and the trematodes. Cystodes are generally ribot-like. The body is made of many units, and the body is dorso-ventrally compressed. So the thickness is small, but it could be long. It could be meters, like the tapeworm Taenia saginata and Taenia solium. The trematode or flukes are somewhat globular in structure and leaf-like, and they contain also parasite of different systems. There is a third group of the parasites, multicellular parasites, known as the Acanthocephala. The head is provided with spine-like structures or hooks. But we said there is only 4 species, and they are very occasionally reported infecting man. Of course, the third group, which is taught as part of entomology or of parasitology, is what we call medical entomology or arthropods of medical importance, because many of them, they are either injurious by their activity, or they are vectors transmitting diseases. They can transmit viruses, they can transmit bacteria and parasites. Then we give an idea about the causative agent of dysentery, which is Entamoeba histolytica. And we said it is called histolytica because the enzymes produced by this parasite can lyse the tissue of the intestine, so they can cause they can cause extraintestinal infections when they break out of the intestine, enter circulation, and they are carried to various organs, particularly making lesions in the liver, and also could be in the lung or brain or even skin. But predominantly, most of the amoebiasis is causing amoebic dysentery, which is bloody mucus containing diarrhea with abdominal cramps and pain. We said there is other two species or two groups of free-living amoebas. These are the Naegleria species and Acantha amoeba species. And we said the Naegleria usually are found in water, especially, for example, they could also be part of the swimming pools if they are not clean, but usually they are found in open, small pond water. So people who swim, because this is a sport, the parasite usually gets through the nasal openings, and from there it invades the brain, and they can cause a very severe meningoencephalitis, which could be fatal within a couple of days. The other species of the group Acantha amoeba may be causing problem in the eye and also in the brain, and recently it was noticed that people who use contact lenses, they have to be careful because it may cause many infections due to cleaning the lenses with unsterile solutions. So please, if you are using a lens, an eye lens, be careful that your cleaning solution is always sterile and clean. Today, mainly, we're going to talk about the flagellates and the ciliates with example, and we'll be dealing whatever species we choose. It is also going to be an overview and a brief introduction. One important flagellate, which is very common, is what we call Giardia lambelia. It is also known as Giardia intestinalis, or also known as Giardia duodenalis, because it is a parasite that inhabits the duodenum or the upper small intestine. So it is important to have a common language with your clinical microbiology to which name to use, is whether lambelia or intestinalis or duodenalis. This parasite, as you have seen here from the slide, it has different forms. Also, like Entamoeba, it has a trophozoite as well as a cyst stage. And usually it is acquired by ingestion of mature cyst, that is a cyst containing 4 nuclei, which is ingested in contaminated food or water. And the parasite, as you see, for example, from the scanning electron micrograph to your right, it has on the ventral anterior side a sort of a cup or a cavity known as suction disc, by which it holds to the intestinal villi, and in this case sometimes it could be in very big number to cause atrophy of the intestinal villi. So precisely, I would like to say the life cycle of Giardia lambelia consists of 2 stages, the trophozoite and the cyst. From what you could see, the trophozoite is pear-shaped with 2 nuclei. They look like eyes. And of course, there is structure in between. So some people, they call it the smiling face. I don't see any smile, but it has 2 big eye-like structures, and these are the 2 nuclei. The parasite, from the scanning electron micrograph, you could see there is some wavy web-like structures, and these are the flagella. So usually it has 4 pairs of flagella. And the suction disc is very clear, by which it attaches to the intestinal wall. The mature infective cyst is oval. You could see it to the left, and it has thick wall, and usually it may be with 4 nuclei. If it is infective, it is mature with 4 nuclei and several internal flagella, because the trophozoite just contracts and then it secretes a cyst wall around all structures. So after ingestion, the cyst can give rise to trophozoite when it exists in the duodenum. And usually transmission occurs by ingestion of the cyst in fecally contaminated food or water. And as I said at the beginning, it may reach large numbers, which cause interference with the fat absorption. The infected patient will not be able to absorb fatty food. And in many situations, it's associated with a variety of symptoms. Most notably, it causes diarrhea, and the diarrhea could be just abrupt, and steatorrhea. Steatorrhea, it means greasy stool, and the patient may suffer from bloating. He feels he's almost having a lot of gases. It may end up causing fatigue, weight loss, anemia, and malabsorption, mainly malabsorption of fats and fat-soluble vitamins. So in infected children, it may cause retarded growth, especially if they are not eating well. Just to summarize the symptoms for you in the slide, the patient may suffer from abdominal cramps, from foul-smelling diarrhea, flatulence, steatorrhea, fatigue and weight loss, malabsorption, and anemia. And as I said, children may suffer from retarded growth. How do we diagnose this parasite? It is by examination of stool to see the cyst and trophozoite in stool. Of course, now there is a more advanced technique. Treatment is usually by metronidazole, and if you remember, I said metronidazole, which is known as Flagyl, is a broad spectrum which could be used against all intestinal protozoa. We'll just make it brief and stop here for Giardia. Another parasite of the urogenital system. Okay, maybe before that it may be worthwhile to mention, beside Giardia, the other Trichomonas which could be found in the intestine is Trichomonas hominis. Hominis inhabits the colon and produces no recognizable disorder. So we consider it as just a commensal. There is also Trichomonas tenax, Tenax, is a parasite of the human mouse, and sometimes it is found in persons with inflamed with gingivitis. So precisely of the Trichomonas, we have Trichomonas hominis and Trichomonas tenax, and the Trichomonas vaginalis. And it is called vaginalis, but this is used found both in male and female. So Trichomonas vaginalis inhabits the genitourinary tract of men and women, and it may cause vaginitis, inflammation of the vagina, and may be associated with non-specific urethritis, inflammation of the ureters. The vaginitis is usually characterized by petechial lesions and profuse, thin, foamy yellowish discharge. It is inoffensive, somewhat foamy. It looks a lot of gases, and it is thin and color and texture. Usually in men, the parasite resides in the urethra. It lives in the urethra, prostate, or seminal vesicles. However, most infections by men, they are not showing any symptoms, and we call them asymptomatic. In general, transmission is by contact with contaminated articles, and also it could be through sexual or mainly through sexual intercourse. Usually diagnosed by finding the trophozoite in the discharge or urine, and usually metronidazole is the drug of choice. Just to make a summary, Trichomonas vaginalis, it exists only as trophozoite. It's not like entamoeba, it's not like Giardia with both trophozoite and cyst. We said the cyst in entamoeba and Giardia, they are for transmission. Here transmission is direct, usually through sexual intercourse. And we said that the parasite multiplies on the epithelial cells of the vagina and urethra of females, and in the urethra, prostate, and seminal vesicles of males. As I emphasized, just wanted to emphasize, infection of male is usually asymptomatic. However, it can cause prostatitis and urethritis. And the symptoms in the female, they vary from mild itching, lesions, to frothy, yellowish, thin offensive discharge. Diagnosis is by recovery of trophozoite in the discharge or in urine. Treatment or recovery at X is through administration of metronidazole, and here it is advisable to treat both. If the husband is infected, the wife should be given treatment, and vice versa, because the parasite makes here what is known as ping-pong infection. The husband can give it to his wife and vice versa. So if one of them is infected, it is advisable to treat the other spouse. We have another parasite which is of minor importance. I will just mention it. It's not in the slide, known as Dientamoeba fragilis. And this parasite is characteristic between entamoeba and as well as the flagellates. So it's not an amoeba properly and not flagellate properly. So most infections are asymptomatic, and also it doesn't have cyst. However, some patients may develop abdominal discomfort. They may suffer from intermittent diarrhea, anorexia, and weight loss. And usually, diagnosis is by recovering of Dientamoeba fragilis in stool, and iudeconol with tetracycline could be administered. So please, just it means whatever I'm saying in the slide is just covering part of what should be learned. We come to blood and tissue flagellates. The photograph here is showing you parasites which look almost wavy, and they belong to two different groups or genera. Leishmania is a genus and Trypanosoma is a genus. However, if you look to the structures here, which has by arrows and lines are giving, for example, if you look to your right, there is basal body, there is kinetoplast, then there is the nucleus, there is undulating membrane, and there is flagellum. So if you look to these structures, they are common to the different parasites here. These are different developmental stages, could be of Leishmania as well as for Trypanosoma. Okay, so morphologically they look different, but the structures are almost typical for all. Maybe in case of the A mastocyte, which is to the left, which looks oval, you don't have a free flagellum, and also for the promastocyte you have a free flagellum, but only starting from the very anterior part of the parasite, so it's not forming an undulating membrane. The flagellum is a web-like structure, and in case of the epimastocyte and trypomastocyte, it is joined to the body by a very thin membrane, forming undulating membrane. So the parasite moves by the beating and motion of the undulating membrane as well as the free flagellum. Members of Leishmania and Trypanosoma are capable of existing during development in more than one form. And this ability of going through different morphological forms in the life cycle is known as polymorphism. So members of the Leishmania and Trypanosoma are polymorphic in structure. So we'll start with a disease known as Leishmaniasis, which is due to the infection by different species of Leishmania. So Leishmaniasis is a group of chronic diseases with irregular pyrexia, that is fever, and usually this fever is caused by the flagellate of the genus Leishmania. For simplicity, we can divide the different groups of Leishmaniasis into what is known as visceral Leishmaniasis, known as Kala-Azar, and also known by other names, as you will see later. Then we have cutaneous Leishmaniasis, or what we call the oriental sore. And it could be cutaneous Leishmaniasis of the Old World and also of the New World. And then we have which is known as mucocutaneous Leishmaniasis or Spondia, and also known by other names. Okay, precisely these three different forms, each form may be caused by one or more species of Leishmania. So Leishmania donovani, which is caused in Kala-Azar, predominantly it causes visceral Leishmaniasis, which is an infection of the internal organs. However, it is capable to form also cutaneous and mucocutaneous Leishmaniasis, and consequently other species which are predominantly causing cutaneous or mucocutaneous can cause other species. So please, when we mention one species, it is that this species, it means making that kind of infection or disease. So precisely we can say visceral Leishmaniasis, which is known as Kala-Azar or dum-dum fever, is found mainly in Central Africa, in India, as well as in the Middle East. Maybe in most of those areas it used to be prevalent once, but now it may be due to development, etc. It is becoming very few cases, if any. So visceral Leishmaniasis or Kala-Azar is caused mainly by Leishmania donovani and Leishmania infantum. So these parasites invade the reticuloendothelial cells of the spleen, liver, lymph node, bone marrow, and small intestine. Please notice these parasites, they invade the macrophages of those systems. And the parasites, Leishmania donovani and infantum and other species of Leishmania, are transmitted by what we call sandflies of the genus Philopotamus. And we call flies sandflies because usually these flies, they breed in water-soaked soil. So they lay the eggs in soil or earth where there is plenty of water, and then they go through developmental larval stages, and it is very difficult to detect the areas or the places where sandflies usually breed. In nature, many animals act as reservoirs. So the cats and the dogs and many rodents are the main reservoirs of these parasites. And in general, Kala-Azar is characterized by fever, weight loss, splenomegaly, and anemia. And in a few cases, it may be fatal. It causes death. So just to see the development and progress of the disease, visceral Leishmaniasis, this is an African child, and you can see there is some ascites and emaciation, thinning of his limbs. So during the first to the 4th month, the patient may suffer from fever, from chills, diarrhea, and dysentery. And comparatively, there is progressive hepatosplenomegaly. And some, especially dark-skinned people, they may suffer from skin hyperpigmentation, so that they have almost a tiger skin. If untreated, visceral Leishmaniasis could be fatal. I got these photos from my colleagues who work at the Institute of Endemic Diseases in Khartoum, Sudan, and I think they have taken it in 2014. There was an epidemic of Kala-Azar in Khartoum and area around it, although Kala-Azar may be found in different parts of Sudan. And these patients are suffering from what we call post-Kala-Azar dermal leishmaniasis. After treatment, some patients they can suffer from this condition, which we call it post-Kala-Azar dermal leishmaniasis, PKDL, post-Kala-Azar dermal leishmaniasis, and they can be getting better by time. We come to the second form of leishmaniasis, which is known as the cutaneous leishmaniasis, also known as oriental sore or Delhi boil. So it means also common in the Indian subcontinent. Usually, at the site of bite of the sandfly, the lesion starts as a red papule, which enlarges and then it ulcerates, make lesions. It has two forms. As I said at the beginning, we have what is known as the old world form of oriental sore, and usually the species of flies that transmitted, they belong to the genus Phlebotomus, so transmitted by Phlebotomus sandflies, and usually this old world form is endemic around the Mediterranean coast and also in the Middle East. It is caused by different species of Leishmania, but the most important ones are Leishmania tropica and Leishmania tubica. And if we wanted to go in details, we have Leishmania tubica major and Leishmania tubica minor, and the lesion caused by these different species could be helpful to identify the species, because some of those lesions are with a lot of exudate, some of them are very dry and crusty, etc. Here I'm showing you what is known as typical cutaneous lesion and atypical cutaneous lesion on the face. So it is clearly different forms, and maybe, for example, the atypical one may be mistaken that the patient is suffering from a sort of leprosy, so they can cause almost what is known as social stigma. The people that try to avoid somebody who is having leprosy. And I think I have seen the gentleman who lost his nose or septum of the nose in yesterday's or in the previous lecture. Just to show you different forms of cutaneous leishmaniasis, so they vary from almost very crusty and hard lesions to almost something protruding, and to somewhat, if you see in the young baby, almost very ugly lesion. Sometimes the lesion can go to eat all the tissues up to the bone, and in many situations it may need decorative surgery. We have also what is known as disseminated cutaneous leishmaniasis. For example, you could see this back of this gentleman as well as on the face of the other one. So this is the infection, or takes different shapes. We come to the new world form, and usually we call it new because mainly it is happening in Central and South America, and the species of the parasite is known as Leishmania mexicana. From the name, it is possibly very predominant in Mexico. The third form is what we know as mucocutaneous leishmaniasis, known as Spandia or UTA. So this form is mainly occurring in South America and is caused by Leishmania brasiliensis. So it starts at the site of infection as a metastatic lesion, and it forms around, for example, the nose and the mouth or any surface, mucus containing surfaces, and it may destroy, for example, the nasal cartilage, and different species of Leishmania mexicana or Leishmania mexicana and Leishmania brasiliensis are transmitted by sandflies or different species of sandflies belonging to a different genus. They are sandfly, but a different genera, not Phlebotomus, but known as Lithomia. This is mucocutaneous leishmaniasis. The patient is losing his nose and septum, a lot of deformity. The other guy is having a lion face, which looks like liboromatic face. So it creates a lot of social stigma. How can we diagnose species or infections with leishmania? Of course, we can examine, in case of the visceral one, we can examine blood, bone marrow, or spleen aspirate, or we can culture them, the bone marrow, the blood, and spleen aspirate, and also known as the triple N media, which is Novi McNeil Nicole medium or Schneider Drosophila medium. So it is by examination of this. Of course, if you are suspicious of leishmaniasis, of course, if there is a lesion, you can make lesion scraping. If it is visceral, you can take blood. You don't go for the bone marrow or spleen aspirate because to collect those specimens, this was known as invasive techniques. So usually you try to avoid invasive technique unless the other safe tests are negative and you have a high suspicion of the infection. So you may need to go for bone marrow or spleen aspirate through invasive techniques. Treatment is by administration of pentavalent antimalarial compounds like sodium stibogluconate, commercially known as Pentostan, or also you may administer or give amphotericin B. The other flagellates of the blood and maybe tissues is known as trypanosomiasis, caused by different species of trypanosomes. And to your left, you see red blood cells and somewhat pink wavy structures. These are the trypanosoma. Here, clearly, these parasites are intercellular, not intra, not living, not inside the cell. However, one species causing Chagas disease, or what we call South American trypanosomiasis, can also be an intracellular parasite. That is Trypanosoma cruzi. Okay, Glossina, which is also known as tsetse fly, is responsible for transmitting 3 different species of trypanosomes in Africa. And these are Trypanosoma rhodesians and Trypanosoma gambians. The bug down is responsible for transmission of South American trypanosomiasis, and it is known as kissing bug or radiophyte bug. So the African trypanosomiasis is caused by Trypanosoma gambians, which causes chronic West African form of sleeping sickness, and the patient can live for a couple of years or long years, while Trypanosoma rhodesians causes acute East African form of sleeping sickness, and by acute it may be fatal within a couple of months or a year. We have a third parasite known as Trypanosoma brucei. It is causing Nagana disease in animals, mainly in cattle. And many people, they say, had it not been for this parasite, those Central African countries could be main beef producers. In general, all these species are transmitted by tsetse flies of the genus Glossina, different species that transmit different forms or species of trypanosomes, like Glossina palpalis and Glossina morsitans, etc. In general, the African trypanosomes cause long continued pyrexia and glandular enlargement, especially of the glands of the neck, a condition known as Winterbottom's syndrome. Of course, they can cause headache and they can cause insomnia. Usually in the late stage, the parasite invade the central nervous system and they can cause many manifestations such as mental retardation and coma, and then they can lead to death. We come to the American trypanosomiasis, which is known as Chagas disease, and Dr. Chagas contributed to our knowledge of this disease, and that's why the name is given as Chagas disease. As we said, it is caused by Trypanosoma cruzi in South America. Unlike the African parasite, which are transmitted by the bite of tsetse flies, here transmission is by the feces of the bug, which is known as the radiophid or kissing bug, different species of bugs. Usually, these bugs are found in people who are living in shabby huts or simple residential areas where there is bugs that can breed in the houses. And usually the bug, when people are sleeping, the bug can dwell on their faces, and usually, possibly that's why this is the name kissing. And if it bites, it has tough proboscis, which is very irritating. So after the bug bites, the sleeping person will just rub, would be irritated, and he would rub, for example, at the lesion left by the bug. And usually if there is feces containing the parasite, the feces can go into the eye, and there they can cause the infection. So it is caused primarily lesion in the form of what is known as glaucoma, which is precisely swelling of the eye and conjunctiva, resulting in conjunctivitis. And this condition of swelling of the eye is known as Romano sign or glaucoma. The parasite, as I said, it could live intercellular and intracellular, so it could be capable of causing neural damage and produce cardiomyopathy and megaesophagus and megacolon. The parasite can invade these muscles of the heart, of the esophagus, and the colon, and they can destroy the muscles. So it results in almost an enlarged or uncontrollable or not muscular structure. So it can cause heart problem, esophagus, or colon. Trypanosomiasis is diagnosed mainly by examination of blood, lymph node aspirate, and cerebrospinal fluid, because the parasite can go to invade the central nervous system. Also, it could be by looking for antibodies or serology. And for Chagas disease, xenodiagnosis is also a test for infection. And by xenodiagnosis is by allowing laboratory-bred bugs, which are free of infection, to feed on the suspected individual. And then after 1 or 2 weeks, the bugs should be crushed to see if there is parasite in their intestine. The good news, many of the South American countries, they have done good control measures, and now very few cases are there. Treatment of trypanosomes or trypanosomiasis in general, there is different medications. For example, suramine and pentamidine is administered in acute stage of the infection. Melarsoprol given in chronic disease, and nefertumox is given for Chagas disease. How can we prevent and control? We know transmission is either by the tsetse fly or the bugs. So control of tsetse flies and bugs is breaking the life cycle, because those vectors are no longer there. And of course, if you can treat all infected people, then even if there is flies or red bugs, there is no problem, because they are not infected by the parasite. However, in the African trypanosomiasis, as well as also in the Chagas disease, there is other animals which could act as reservoirs. For example, many of the wild game animals in Africa, they are natural reservoirs of the parasite trypanosoma. Thank you very much. This brings me to the end of this lecture. Wish you a nice time, and see you next time. Assalamu alaikum wa rahmatullah.